Hello, this is the Kratom Sobriety Podcast. My name is Charlie, and this week we have a special interview on a Wednesday with Dr. Casey Grover.
Thank you for having me.
We both have podcasts, and recently you had a couple episodes on Kratom, and they were very interesting, so thank you.
Yes, I'll give you a brief background about how I ended up doing what I do now. So I originally trained in emergency medicine. I did med school at UCLA and residency at Stanford, so fine academic institutions. And I got in 7 years, 1 hour of training on addiction, and that was on gambling addiction. I got interested in addiction as a medical student, working in homeless clinics, helping people who inject drugs, doing wound care and syringe exchange services. And I went and did my career in emergency medicine and didn't really think much about addiction. I was taught to judge people with addiction and treat them with stigma and make them feel bad because that was clearly going to make them stop using. I obviously am making a point here that was very wrong. And my spouse is also an emergency doctor, and she took care of a child who overdosed on opioids and died in 2013 and said never again. And so we've spent the last 12 years in Monterey County here in California trying to prevent overdoses. In the last 5 years, we've realized that treating addiction is the single biggest difference we can make. So we both transitioned to addiction medicine, and then through our practice, we're able to qualify to be board certified in addiction medicine. And we've both taken the boards and are now board certified in addiction medicine. So I quit the ER, which is a whole nother story. And now I do addiction medicine as my full-time job. And Kratom is a very interesting topic. I probably ran into it about 8 years ago, and no medical doctor knows what it is. We're clueless. And recently, I've started to come back to it as patients come to me saying, I'm on Kratom and I want to stop. And I've gone down the Kratom rabbit hole. And my patients that use Kratom are very grateful that I have at least some expertise on this. And so that's how we connected. My podcast is Addiction Medicine Made Easy. And I've had a string of Kratom episodes in the last 4 months, maybe 4 or 5 of them. And I'm very honored to be here.
Thank you. And most of our episode today will be on Kratom, but could you give us a larger context as an addiction doctor? What keeps you up at night about the overall drug overdose crisis, or what some people describe as a poisoning crisis?
People have learned to fear fentanyl. I spoke to over 5,000 students in 2024 doing education at schools on drugs and alcohol. And the kids, they know what fentanyl is. They've heard about it. They know to be worried. Fentanyl is not the worst to come. So in the opioid world, we started with the overprescription of opioids. Thank you, Sackler family and Purdue Pharma. We then pivoted to heroin because as doctors, when people had a problem with opioid pain tablets, we cut them off rather than recognizing their dependence and withdrawal. So heroin was the only opioid people could get. And heroin's a lot of work, right? It's a plant. You have to grow it. And fentanyl is just easier if you're in drug dealing. If you take a sugar packet and you fill that with fentanyl, that's enough for a dealer to sell 40,000 doses on the street. It's just easier if you're dealing drugs. And unfortunately, fentanyl is not the worst to come. Fentanyl is easily modified in a lab, which means we now have all these fentanyl derivatives or analogs, furanylfentanyl, acrylfentanyl, acetylfentanyl, methylfentanyl. I can go on. And unfortunately, we're now getting into this realm of research chemicals, which involve substances that were never meant for human consumption. And the one that comes to mind is isotonitazine and the nitazene opioids. They are synthetic opioids that no one's ever heard of. And I lecture on this professionally. In other words, I lecture on what's coming next in the opiate crisis. And when I was trying to give a lecture on isotonitazine, I could not find any scientific research on it. But I found a drug company in Hong Kong that was willing to ship me 1 kilogram a week, up to 500 kilograms a week. So that's where we're at. We have synthetic opioids that doctors know nothing about being shipped by the kilogram from pharmaceutical companies in other countries.
Wow.
And the worst part of it is these pharmaceutical companies in other countries are so brazen that if you order from them and your shipment gets seized in customs by law enforcement, they guarantee they'll replace it for free.
That is nuts.
You can find it on the web. It's not even the dark web. I mean, you can Google buy fentanyl online. We recently found a fentanyl in Monterey County called hexanoyl fentanyl. So I Googled it. And the first hit was a company in the Cayman Islands wanting to sell me hexanoyl fentanyl.
The reason I bring up the question is I often get asked, why are you fussing about kratom? And especially when there's these bigger problems out there. And personally, I became addicted to kratom, and I now am involved with this community with hundreds of other people that were also affected by it. And you have the same experiences. You have patients that walk into your office who are having trouble with kratom. So we can worry about many things at the same time and put that in the context of what problem they are. Can you talk about some of your patient interactions, especially along the lines of people who might have disordered kratom use?
Sure. So the first thing I wanted to bring up is the labeling of kratom. And on my podcast, I interviewed the Global Kratom Coalition, and they have a particular perspective as insiders in the industry on what should happen. And I was actually pleasantly surprised that they want labeling like cigarettes and alcohol, that this substance can cause a problem. Here's where I struggle with kratom. When a person takes opioids regularly, they develop what's called opioid dependence. They are dependent on the substance, their brain chemistry changes, and when they stop using the substance, they develop withdrawal. Now, where people on opioids get frustrated is they are ready to quit, but their brain chemistry and body are not. And I can't fix opioid dependence quickly. And that's a frustration about Suboxone, which we can talk about, is my patients come to me, I'm ready to get off kratom, and I say, great, what are we going to do? The options are is you can kick, you can withdraw. I'll give you medicines to make the withdrawal not so bad. But that's up to a week of nausea, vomiting, diarrhea, body aches, chills, horrible flu-like symptoms, right? I think I didn't say diarrhea, I said rhea, but it's diarrhea, sorry. Or we can put you on Suboxone and then you're not feeling sick, but you're still dependent on opioids. And I think that's a major frustration with Suboxone is, yay, I'm off kratom, I'm on Suboxone, but now I got to get off Suboxone. I'm still dependent on opioids. My issue with kratom is that people get on it not knowing it causes dependence, and then they're stuck. And it's anywhere from a miserable week of withdrawal, nausea, vomiting, diarrhea, like I said, body aches, chills, horrible anxiety, or it's a slow weaning process off of Suboxone or methadone. And I think the issue for me is that a person getting on kratom can be life-changing in trying to deal with the dependence. And it's not labeled anywhere that's an issue. And in terms of various substances that I get people off of, alcohol is actually fairly easy. We give people a benzodiazepine like Valium. I give them a week's worth and they're good. Opiates aren't like that. And kratom, depending on what you think about it, kratom, some people say it's not technically an opioid. I think of it as an opioid because it acts the opioid receptors in the brain, and I treat it like an opioid. And then you have the extracts and synthetics, the 7-O's, and those are really opioids. But yes, I think that's where I struggle is people start saying, well, I'll take kratom. I'm more productive. And then they can't quit because they feel sick. And then it's 6 months of working with me to taper. So I think that's my biggest frustration with kratom. Now, granted, it is so much less likely to cause a fatal overdose compared to fentanyl. And that's the argument the kratom people make. But it's not a benign substance, and it can absolutely change a person's life in a very bad way.
Yeah, I liked one of your episodes you labeled, at least it's not fentanyl.
Yes. That was my colleagues on the Addiction Medicine Journal Club. We did some joint episodes on kratom. Yeah, they're good folks. They're out of the East Coast.
Yeah. Do you have some patients, some case stories you could share with while respecting privacy to kind of give an example of how you treat kratom addiction?
Yeah, absolutely. And what I'm going to do is I'm going to change details about the patient and change names so that the person's privacy is protected. But yes, this is what we do in medicine is we learn from taking care of patients and sharing it with other clinicians. So I took care of a young man about a month ago who had used kratom because it made him more productive. And every time he tried to quit, he went into horrible withdrawal. And he had tried to quit multiple times, and willpower wasn't the issue. He was very dependent, was using the 7-O's. So those are synthetic. What's best way to say it? There's a synthetic chemical derived from the kratom plant that is a very potent activator of the opiate receptor in the brain. And so what he and I did is we came up with a time that he could go through the withdrawal required to get on Suboxone. So he was working and he didn't have to work Monday or Tuesday. So Sunday night was his last dose of kratom. I gave him a non-addictive sleep aid. and then some non-addictive medications to make the withdrawal not as bad. And I can talk about those. And then he went through it overnight. He was hot tubbing the next morning to try to feel better. And by about noon the next day, he was on Suboxone. And so he's now on Suboxone, and we're in the process of weaning him down. His goal is to get off opiates altogether. I could share another case of a young woman who came to me after asking too many doctors to count. Can you help me with kratom? And they said, help you with what? And the staff in this particular clinic I was working in asked if I knew anything about kratom. And I said something to the effect of, yes, I'm a total kratom geek. This is absolutely what I'm good at. I have a lot of experience from podcasting about it and taking care of patients with it. And the patient just walked in and just gratitude of, I'm so glad I found a doctor that actually understands this stuff. And her path is a little different. We took her from kratom to Suboxone, and now she's on the once a month shot for Suboxone called Sublocade. And I will give her somewhere between 4 to 6 injections of Sublocade, and then she will just stop and she will not go through opioid withdrawal. The shots are fantastic. And I am not paid by any drug manufacturer. If you look me up on some of those websites where doctors have to disclose how much they get paid by drug companies, I think it's like $15, and I don't even remember the coffee that they gave me. There's no industry ties here. Sublocade is made by a company called Indivior. I try to keep pharmaceutical reps at arm's length. They're lovely people, but I don't want bias. But Sublocade is my preferred product. It's essentially 4 to 6 weeks worth of Suboxone in a single shot. It goes under the skin of your abdomen. And if you give sequential injections several months in a row, you build up enough buprenorphine, that's the active medicine in Suboxone and Sublocade, that essentially you have a depot in your body, and then your body metabolizes it over the next 6 months. So weaning involves the process of taking your medicine, dropping your dose, feeling a little bit of withdrawal, stabilizing, dropping your dose, feeling a little bit of withdrawal, stabilizing. You have to actually feel it. With the Sublocade, because your body metabolizes it over 4 to 6 months, the amount of a dose drop that happens every day as your body breaks it down is so tiny that you can't actually feel it. What I'm working with this female patient is she's been through withdrawal too many times to count, has tried to get on Suboxone and wean, can't do it. We're going to give her Sublocade until she's built up enough medicine, and then she just stops and she sees me every month, and I will get her free of opioids.
Excellent. Yeah, we've heard comments that shot is working well among our audience. As an addiction doctor, you probably most often hear bad cases of kratom use, but have you ever interacted with any of your patients that have had a positive experience?
So that's a great question. And the answer is, if someone's having a positive experience, they don't bring it up to me.
Yeah.
So no one goes to the addiction medicine doctor and says, hey, I smoke cannabis once a week and it's great. I have a bias in that I only see people with a problem. And the same in the ER, right? No one goes to the ER after surgery to say, I just had surgery, I'm having a great day, right? It's I had surgery, I'm bleeding, I've got a fever, whatever. So there's a bias there. Now, that being said, we do drug testing for kratom in my office. So if someone tests positive, I will ask them about it. What I would tell you is I'm sure there are people out there that can use it without escalating use or use it intermittently or don't deal with withdrawal, but that's not who I see. It's probably the same with alcohol. People who have a couple of drinks on a Saturday night, they don't need to see me. So I obviously have a bias in who I see. None of my patients who I've seen for kratom have had a good experience with it. They all tell me, Dr. Grover, this is a horrible substance, please get it banned, because of the experience that they've had.
By far the most controversial issue for our podcast and in the quitting kratom community is the use of Suboxone as a treatment method. It's a lightning rod.
Here's my approach to the treatment of any addiction. If you, Charlie, told me I'm struggling with kratom, but when I put mayonnaise on my left ear, I don't crave kratom and I don't use. You know what I would say? Let me buy you a jar of mayonnaise. In other words, whatever gets someone to their sobriety goals works for me. So if a person using kratom came to me and said, I don't want Suboxone, I would say, okay. If a person using kratom came to me and said, I want to use Suboxone, I would say, okay. The issue, though, is because kratom activates the opioid receptor, it causes opioid dependence. And I cannot, nor can any doctor, fix that quickly. You either have to replace the opioid with another, like Suboxone or methadone, or you have to go through withdrawal. That can be all at once, or it can be tapering. So I support anyone's approach to sobriety as long as they are committed to it. So I'm not stuck on Suboxone, but I'm a doctor. I'm not a surgeon. So what's my primary tool? Medication. And for me, in the world of opioids, Suboxone is fantastic. But I have plenty of patients that are like, no Suboxone for me. And I say, okay, let's come up with another plan.
For our listeners, many of them got addicted to pills in the 2000s, and then they got to Suboxone, and they might have done a merry-go-round between the pills and Suboxone, but they ended up having bad experiences with Suboxone. Either they weren't able to taper, they had horrible withdrawals, or they felt stuck, and that's how they ended up getting hooked on Kratom. And so they feel this obligation that they need to warn the world about how bad Suboxone is. That's where we find ourselves. Just people have really strongly held beliefs around this.
Yeah, let me comment on that. So the problem is not Suboxone. The problem is opioid dependence.
Yes.
So first of all, I need to apologize on behalf of the medical community to those pain patients. I lecture professionally on the history of the opioid epidemic in America. They are the victims in this. I am so sorry for anyone who listens who got hooked on opioids in the 2000s. And then also legitimate pain patients are really struggling in 2025. In my practice, the other half of the practice is pain medicine. And sometimes folks that were on these ridiculously high doses of opioids in the 2000s get sent to me because they're asking for higher doses of opioids for their pain. And a lot of what I do is just explain what's happened, and I acknowledge that they're struggling, and we try to come up with other ways to manage their pain. But it's not a Suboxone problem. It's an opioid dependence problem. And I realize people are entitled to whatever opinion they have. I just finished Matthew Perry's book from Friends, right? I think it's Friends, Lovers, and the Big Terrible Thing. He talked about Suboxone was the single hardest drug to get off of. And it's an opioid dependence thing. I worked with one patient for 15 months to wean him off of methadone. 15 months. So this is why I love, and again, no industry connection here, this is why I love Sublocade. Because I can get you off of opioids essentially pain-free in about 4 to 6 months. And all you have to do is show up and get the shot. It is life-changing. Now, that being said, commercial insurance companies fight me tooth and nail to give it. It's about $2,000 a dose. Where I am in California, our Medicaid is called Medi-Cal, and Medi-Cal is amazing. I write the order, it's delivered a week later, I get people on the shot. Commercial insurance, they fight us, they deny it, they fight us, they deny it. It's so frustrating. Now, here's what I think needs to happen. And the Sublocade rep was in my office this week, and this is what I told her. The FDA only approved Sublocade for the maintenance of opioid dependence and opioid use disorder. Using it to wean off opioids like this is off-label. Medi-Cal doesn't care, which is great, but the private insurance companies do. What we need to do is get Sublocade approved for the successful cessation and weaning off of opioids, and then and then insurance companies will be likely paying for it because it's cheaper to pay for 4 shots rather than 3 years of Suboxone.
Yeah, I have an interview set up with a listener who paid out of pocket $2,000 to get the Sublocade shot because they found it was the most effective way for them to get off Kratom. So another issue with the Suboxone is whether you should use it short term, just to detox off the Kratom and avoid the withdrawal symptoms, the acutes, or is it proper to use it long term? Do you have any clinical experiences or research and give us any instruction about that?
I have this conversation all the time with my patients. So I think we need to realize that there's a lot of shame and judgment and stigma around addiction. Okay. If a person who's listening to this podcast got addicted to Kratom, my heart goes out to them because frankly, it's brutal and they may face judgment the rest of their lives. However, addiction involves profound chemical changes in the brain. And why do humans use substances? Right? All of my patients have a reason why they use. For Kratom, it might be that they have untreated ADHD and the stimulant effects help them be more productive. It might be that they were sexually assaulted as a child and the opioid-like effects are soothing. When people are suffering from any addiction, there are three major milestones in the recovery. There is the 6-month milestone, which suggests a transition from short-term to longer-term recovery. There is 2 years of sobriety when the brain changes from addiction have gotten fairly close to healing. And then there's 5 years of sobriety, which person at that point, their risk of an addiction is pretty similar to the general population. That's like long-term healing. A lot of what I see is people get off of fentanyl or kratom or oxycodone or whatever, and they've been on Suboxone for 2 weeks. And they're like, Doc, I got this. I'm ready to quit my Suboxone. And my answer is no, your brain is not ready. Please give me at least 6 months. Now, the other issue is we do have data on what happens when people get off of Suboxone. So let's look at people in long-term recovery from opioid use disorder, whether that be from kratom or oxycodone. Let's say someone has been super stable on Suboxone for about a year, and they decide, I'm going to work with my doctor to taper off of Suboxone. And again, just for context, the active ingredient in Suboxone is buprenorphine. So this could be Subutex, which is just buprenorphine. It could be Suboxone, where it's mixed with naloxone. It could be the buprenorphine patches. It could be the Sublocade, any form of buprenorphine. So they've been stable and they want to taper off of it. Within 18 months of completing the taper, 2/3 of people will relapse on opioids, have an overdose, or go back to buprenorphine or Suboxone. Why is that? Unfortunately, our body is constantly seeking to solve problems. And when we have a bad day in sobriety, our brain remembers what used to soothe us. So what I recommend to my patients is once you are done with your Suboxone taper, whether it be from dropping the dose slowly or getting the injection, is you're not done with buprenorphine. Here's why. If you take 1 to 4 doses a week, you will not be dependent. You will not have to go through tapering again. But if you're having a bad day and your brain starts to think, I need to feel better, and you see some kratom, I need you to go to the buprenorphine or Suboxone and not the kratom or fentanyl or whatever it is. And you need to keep seeing me, and we need to continue to do the work of getting into long-term recovery. So yes, I think buprenorphine and Suboxone are so effective that people can get this false sense of security of, I totally got this, when the reality is so much more work needs to be done. Whether that means seeing me to get your ADHD treated, whether that means working through your childhood traumas, whatever it is, we have to go back and understand the why of how we got started in the first place and figure out what unmet need were you looking to fix and how can I help you fix that as a doctor without your substance of choice. And here we're obviously talking about kratom.
So that would be a proper use of Suboxone if you're working with a doctor like a year in, you've weaned yourself off, you're no longer dependent on it on a daily basis, but you have a prescription at home and you could use Suboxone if you're having a bad day rather than going to, obviously that's harm reduction rather than going out to use kratom again. But you actually have a prescription and as needed, you'd use it?
Totally. So let's say, for example, I'll pick on you, Charlie. So let's say you came to me on kratom and I put you on Suboxone at 8 milligrams a day.
Yeah.
You take 1 strip in the morning, you go about your business, you tell me, hey, you know what? I don't like the Suboxone. I want to switch to the mono product, Subutex. We can switch 1-to-1. So I'd put you on 8 milligrams of Subutex. Let's say we give you 4 doses of the Sublocade injection and you are opioid free. I would give you a little baby prescription, just 2 milligrams, which is essentially break glass in case of emergency. I had a bad day at work. I'm having a conflict with my spouse. I'm really triggered. I feel like I'm really spinning. I'm thinking about kratom. That's when you take that 2 milligram. And now we have to realize, what are the emotional states that contribute to relapse? Okay. HALT, hungry, angry, lonely, tired. What makes me a bad parent? When I'm hungry, angry, lonely, and tired, right? What makes me short with my spouse? When I'm hungry, angry, lonely, tired. Our emotional reservoir is depleted. And it might be something that at the end of the day, when you're just really struggling, take just 2 milligrams of Suboxone and we missed the relapse. We were able to focus on healthy things. Even though people may not like Suboxone, it's better than going back to kratom.
I know dosage is very individualized. What's the typical dosing amounts for Suboxone or Subutex for kratom use disorder when a patient walks in?
So it really varies person to person. We did review some scientific literature when we did a journal club with the Addiction Medicine podcast, what we found is that when they look at it, people who are transitioning from kratom to Suboxone, there's not a real correlation between the intensity of kratom use and the dose of Suboxone, but usually somewhere between 4 and 24. With my patients using fentanyl, it's more like 16 to 32.
Most of our listeners would agree that kratom is milder than traditional opioids, but for many of them, the substance is harder to quit because of the difficult withdrawals, the intense cravings, and the ease in relapsing. Do you have any clinical observations or research knowledge to explain why this is the case in some people?
So the question was, why is it that kratom is hard to quit when it's weaker than other opioids, right?
Yes, that's a shorter version.
Yeah. So the answer is it acts like an opioid. Again, kratom is not the problem. It's that it acts like an opioid that is the problem. So kratom, as we know, just a level set, has two ways that it acts on the body that are noticeable to the user. One is at lower doses, it has a stimulant-like effect. And at higher doses, it activates the opioid receptors in the brain. Now, 100% of people who are exposed to an opioid regularly for more than 2 weeks will develop opioid dependence. Somewhere between about maybe 2 and 15% of people who use opioids will develop an opioid use disorder. That's the newer term for opioid addiction. So everyone who uses an opioid regularly will become dependent. So if you give 100 people kratom for 3 weeks, 100% of them will have trouble stopping due to withdrawal, but not all of them will develop the psychological phenomenon of a use disorder. And there are 3 features of a use disorder: cravings for the substance, compulsive use, not being able to stop it, and using despite consequences, whether that's just financial consequences. I slept in because I was too busy using kratom all night, whatever it's going to be. I lost my job, whatever it is. Kratom tends to affect people in terms of legal and familial consequences less than other opioids compared to fentanyl. Kratom is much more benign in terms of people hitting rock bottom, if you will. And there's probably some complicated reasons behind that. One is it's legal, so they don't have to steal to get it. They don't get arrested for having it. So that's probably part of why people tend to have a higher rock bottom with kratom as opposed to an illegal opioid like heroin or fentanyl. But an opioid is an opioid. So when they stop, they get sick. And the question is, are they craving kratom, or are they craving to feel better because they're in such bad withdrawal? Now, for somebody who has a use disorder, the craving is a fixation on the opioid itself, whether it be kratom or oxycodone. Dependence is more just, man, I feel awful. I've got to feel better. Let me tell you a brief story about dependence. So the artwork for my podcast is painted by a man named Paul. Unfortunately, we lost him to an opioid overdose in 2019. And he was telling me about a time that he and his girlfriend were using heroin, and she had an asthma attack and had to go to the ER. And he told me that he had to go to the car while she was in the ER and get some heroin and inject it into her IV. And he used these words very carefully: to get her well. And I didn't know much about addiction at the time. I was like, dude, you were getting her high. He's like, no, I knew she was going to be sick. I had to get her so she wouldn't withdraw. And so I think that's the nuance is fentanyl is so much stronger. It's laced with who knows what. It's illegal. It leads to jail. It leads to consequences legally. Kratom is a legal substance that, if the manufacturers do a decent job, doesn't have a bunch of horrible stuff cut into it. It's more an issue of dependence. But again, some people do develop that psychological craving where even if they're off of it and not in withdrawal, they still crave it. That was a convoluted answer. I hope that answered your question.
And all of this is very subjective. I'm not very good at chemistry. My understanding is kratom is like a partial antagonist against the opioid receptor right in the brain rather than a full one. So we just all are left dumbfounded. We're like, why is this such a harder to quit?
So let's unpack this, right? Let's go back to, you mentioned people were pain patients back in the 2000s. Okay.
Yes.
At the time, we gave out a lot of Vicodin. Yeah. Vicodin is an opioid that contains 5 milligrams of hydrocodone, which is a very weak opioid. Okay. In terms of how dependent a person is on opioids, a regular user of hydrocodone might be like a 1 or a 2. Yeah, they'll kick. Yeah, they get withdrawal. It's fairly mild, and they might need Suboxone. Okay. Fentanyl is very different. Fentanyl is something where people get really dependent very quickly. In other words, they go up to a 9 or a 10 very quickly. So in terms of kratom, kratom is something where it depends on the type of kratom used. True leaf kratom is fairly weak, and it has, as I understand it, a very unpleasant taste and a weird mouth texture. So it's really hard to use a ton of kratom in the traditional leaf form. Now, what do humans do when they find a substance they like? They manufacture it so you can get more of it. To table sugar, coca to crack cocaine, right? We've done this before. So let's say you take kratom that's been dried in the leaf form and put into a capsule. You now can get more kratom than you could with the leaf. So now instead of being a 1 or a 2, you're now like a 3 or a 4. Now, let's say you take a kratom extract. That involves processing the leaf and taking out some of the opioid-like chemicals. And now your tolerance might be like a 4 or 5. And then let's say you go to 7-Os. Those are synthetic compounds that are similar to mitragyna that now are like a 7 or an 8. And speaking with the Global Kratom Coalition, essentially these 7-Os are novel synthetic opioids. So the question I ask my patients is not, do you use kratom, but what type of kratom are you using? And each type of kratom is going to result in a different amount of opioid dependence. If you are using leaf kratom, it's like a couple of Vicodin here and there. If you're using the 7-Os, that's more like you using fentanyl. And I don't have precise data on exactly how the tolerances equate, but that's a general framework of how to think about it.
Yeah. Product type really matters a lot. Understanding your experience with kratom. But we do have powder users that have really bad experience with withdrawals and have trouble kicking. And it's probably because the kratom leaf has all these alkaloids, and beyond just the opioid receptors, it does have these SSRI effects and these other compounds in it. All right. This next question is from a listener, actually Matthew, who was a guest a couple of weeks ago. And he observed that all of our past guests who had been on Suboxone before, at the time of their interview, were still on Suboxone. Have you ever had a patient that you treated for kratom and prescribed Suboxone that eventually got off of Suboxone and remained both kratom free and Suboxone free long term?
So unfortunately, I've only been doing addiction medicine in my current state for about 2 years. So I don't have a ton of long-term data. What I can tell you is, in terms of my kratom patients, I have one that I got off of kratom with Suboxone. He weaned himself off of it. And he did have one slip up, but as of about the last 6 months, he's been kratom free. I have another patient who used kratom for many years for pain. And when he tried to get him off of kratom, his pain flared. He was too uncomfortable. So he ended up using buprenorphine. Again, that's the medicine in Suboxone for pain. A third patient, I am in the process of getting off of Suboxone. She is due to get her second Sublocade injection either, I think, last week or in the next couple of weeks. But her goal will be to be buprenorphine free, again, Suboxone free, but I will still give her a few Suboxone like we talked about, just in case. And then I have one patient who's fairly new to me. I got him on Suboxone maybe 2 to 3 weeks ago. So we're just getting started. And then I have one more who's doing fairly well on about a year of Suboxone and is worried about relapse, so is not ready to come off of Suboxone yet. I've treated others in the ER before. I don't have a lot of follow-up data on them, but this is an interesting question. As in terms of what defines sobriety, this was actually my friend Paul, who I mentioned. His art is my podcast logo.
Yeah.
And poor Paul, he used meth and alcohol and heroin and dust off and anything he could get his hands on. And he called me one day and he's like, Dr. Grover, I'm sober. I'm on cannabis and kratom and Valium. And I went, okay, you're not using meth. You're not using heroin. You're not inhaling dust off. Yeah, okay. That's about as sober as we're going to get to today. So yes, it's an interesting question as to how we define sobriety. Really interesting question. But yes, my goal with my patients around any opioid, including kratom, is that they do what feels right to them. I have 2 patients who've been on Suboxone from heroin for about 10 years. One is great. He's a college professor. He's doing awesome. The other is living with her dogs and living her best life. She was able to be financially independent. She traditionally was in a very high stress financial industry and was like, you know what? I'm going to live a simpler life and focus on the good things in life. So she's taking a break from capitalism, if you will. And yeah, my Kratom patients, my goal is to get them to where they feel like Suboxone works for them and they want to stay on it. And then if not, we'll work on getting them off of it, either through weaning or Sublocade. And then again, stay engaged with me in case there is a relapse, or at least we can mitigate cravings with as needed Suboxone.
Do you have any clinical experience prescribing, I'm going to mispronounce these words, naltrexone or Withdrawal?
Withdrawal. Yes. So I have, of all of my patients who've been addicted to any opioid, I only have one on naltrexone. So naltrexone is an opioid blocker. If somebody using Kratom took it, it would put them into horrible withdrawal. Now, naltrexone for opioids, including Kratom, is essentially enforced sobriety. It is a long-term opioid blocker that can be taken once a day as a pill or once a month as an injection called Vivitrol. And the problem is because opioid withdrawal is so bad, so few of my patients can get all the way off of opioids to get on to naltrexone. So this particular individual went through a residential treatment program, went through a medical supervised withdrawal protocol. Basically, he withdrew in rehab, and then he got to where he had no opioids in his system and is now on naltrexone. So yes, if someone came to me and said, Dr. Grover, I want to get on naltrexone, I would say, great, you're dependent on opioids. How do we get you off of opioids, including Kratom, and then you'll be a candidate for naltrexone?
Yeah, we've had a handful of listeners who planned their relapses. They just stopped taking the naltrexone and then very soon they're back to the Kratom. So
yep.
Why is naltrexone put in Suboxone?
Yeah, this really goes back to a lack of understanding about addiction from the medical community. Buprenorphine is the active ingredient in any sort of sub-U product. Sublocade, Subutex, Suboxone. The active ingredient is buprenorphine. Okay. Buprenorphine is an unusual opioid. It both activates and blocks the opiate receptor. It activates it enough to treat withdrawal and prevent cravings, but it blocks it enough that it blocks other opioids and doesn't cause overdose. In other words, it doesn't cause breathing to stop the way other opioids do. So people will sometimes say, oh, I know the precipitated withdrawal that you get from taking Suboxone too early is because it has naloxone in it, and that is not true. Naloxone is meant to be an abuse deterrent. So the Suboxone has naloxone in it so that a person will not snort or inject the product. Because if you snort or inject naloxone, you will get opioid withdrawal, and naloxone is not absorbed by the intestine, so you just poop out the naloxone. Now, you and I both know if people want to get something that's going to give them euphoria, there's way better stuff out there than buprenorphine. There's fentanyl, there's carfentanil. Heroin is gone where I am, but in other parts of the country, heroin could be an option, Kratom, whatever. So it's really just there as an abuse deterrent. And there are doctors that refuse to prescribe anything but the Suboxone. And it makes me so frustrated because the buprenorphine in the MATA product, Subutex, is just fine. If people want to find something euphoric, they will. And yes, it's just there because of this perception that buprenorphine could be misused. And the answer is it can, but it's so much safer than any other opioid. I'm totally fine with that while we work on getting someone more treatment.
Have you seen a patient profile of who might be successful on Suboxone and who might tend to abuse it? We just have so many listeners that say, I just ended up overtaking that and abusing that.
Yes. So let's unpack this. Okay. So I think this goes back to the question of why does addiction happen? Okay. So there are two parts. The first is how you're made genetically. Some people find opioids activating, soothing, euphoric. They feel like I pulled a warm blanket over myself, or gosh, my mood was better. One of my patients, who's actually very depressed right now, thinks that he should go to Mexico to buy opioids because opioids will make him feel better. And my recommendation was absolutely freaking not. But his brain, opioids make him feel better. They give him a positive euphoric feeling. Now, not everyone has that. One of my very dear friends just had surgery, and he called me the day after surgery and said, oxycodone is the dumbest drug ever. I'm tired and I'm stupid and I can't poop. That patient does not have a euphoric response to opioids. Okay. For me, my vice was food. I had bulimia. When I actually took naltrexone to see what would happen, food lost its pleasure. In other words, I have an exaggerated pleasure response to sweets. Chocolate on naltrexone was totally different because my brain releases the chemicals dopamine, which is pleasure, and natural endorphins when I consume food. When some people consume opioids, their brain releases dopamine and some naturally occurring opioids in the brain called endorphins. So a person who has an intense pleasure response to any opioid may get some of that as well with buprenorphine because it does activate the opiate receptor. Now, there's part two. Part two is what happens to you in your life. Let me tell you a story from yesterday in clinic. I have a patient, and this patient has used many different substances, opioids, alcohol, stimulants. And she came to me on opioids, and most recently she's seen me for methamphetamine. And as an addiction doctor, I focused on the substances. I focused on Suboxone. And I asked her and I said, do you have any traumas in your life? And she said, yeah. And I said, do you get nightmares about them? And she said, yeah. Do you get flashbacks about them? Yeah. Do you avoid things that trigger bad traumatic memories? Yeah. So I read through her the criteria of post-traumatic stress disorder, and she met every last criteria. And she had a very high number of adverse childhood experiences, meaning that she's been traumatized. And my patients are very honest with me. They say, Dr. Grover, I feel awful. I don't know what to do when I feel so bad, when I'm triggered, when I'm sad, when I'm depressed, and substances make me feel better. For the traumatized patient, the substance is the cure, except it causes harm. So I have to work with them to get them off the substance and get their PTSD better. So if someone's taking kratom to self-soothe because they were traumatized as a child, stopping the kratom doesn't fix the trauma. And the buprenorphine, because it has some opioid-like qualities, might help them self-soothe. So addiction is a fairly complicated condition because everyone has a genetic difference in how they respond to substances, and their life experiences gives them a different relationship with the substance as well.
Have you ever had a patient that just absolutely abused Suboxone and just it was a disaster for them?
I don't think I have.
Yeah.
Because quite honestly, around here, there's so much fentanyl. If they want to get really euphoric, they go to fentanyl.
I have developed a bias myself because I've just heard so many stories from listeners and also don't ever take medical advice from Reddit, but reading horror stories on Reddit about Suboxone that I have a bias against it now.
So here's my take on that.
Yeah.
We do a horrendously lousy job of educating healthcare providers about addiction. So I mentioned that my lovely wife, Dr. Reb Close, is the other addiction doctor in my practice. She did medical school at UCLA and residency at UCLA in emergency medicine. And I mentioned I did medical school at UCLA and residency in emergency medicine at Stanford. So that is 15 years between the two of us at some of America's best medical institutions. Between the two of us, 1 hour of training on addiction. And as I mentioned, it was at UCLA for me on gambling addiction.
Yeah.
I literally had one of my patients last week show up in his primary care doctor's office in horrible opiate withdrawal, and his doctor had no clue what to do. None. Thank goodness she called me. This is not her name. Thank you, Dr. Smith, for calling for help. So I called the guy same day. I got him on some meds. I got his withdrawal better. I got him on Suboxone. I gave him his first shot of Sublocade this week. Doctors are clueless. I am so sorry to any listener, but we just do a horrendously lousy job of teaching doctors about addiction. And even then, the textbook is all about Suboxone, methadone, naltrexone, antabuse. It's not as much about deeply getting to understand people, why they do what they do, and how to help that. I'll give you an example. There's a condition with cannabis called cannabinoid hyperemesis syndrome. which we're still trying to understand, but basically heavy users of cannabis develop horrible recurrent abdominal pain and vomiting, and it's awful. And they go to the ER, and what do they get told? Stop cannabis. No one asks them, why do you use cannabis? How does cannabis help you? What are your worst withdrawal symptoms? What can we do for your cannabis withdrawal? Did you have childhood trauma? Do you see a therapist? How do you sleep at night? Do you have pain? All they get is stop cannabis. So I would argue that your opinion and your podcast listeners' opinions come from the fact that they have not actually worked with a doctor that understands this stuff.
Yeah.
I'm trying to learn it. I learn the most from my patients. I've learned a ton in the last 6 months about PTSD and trauma. And I've learned a ton about kratom in the last 6 months, and I have so much more to learn. And I want to apologize on behalf of doctors everywhere that the medical community does not educate well on addiction. It's really unfortunate. Now, granted, doctors now have to actually take an 8-hour course on addiction to be able to prescribe controlled substances. And yet I signed up for a course on this, and there was tons of factually incorrect information. So frustrating.
Yeah.
So that's actually why I started my own addiction podcast, is I feel like I can share the best information that I have. And again, shameless plug, it is called Addiction Medicine Made Easy.
And we'll definitely have a link in the show notes to get people there. Have you had any experience prescribing Lucimera for withdrawals for kratom?
Yes. So this is what's called an alpha-2 agonist. I believe it's lofexidine is the generic name. I may have said that wrong. Yeah, I don't really use it because there's better alternatives and they're generic. And let me get really geeky for a second, because you've probably realized by now I am a geek at heart. I will never forget, I was in ER room 9. I always remember where I was in the ER, and a woman came in trying to get off of heroin. And all I had at the time was to offer her clonidine. And she told me, that's stupid. It's just blood pressure medicine. And I didn't know what to tell her. So now that I am board certified in addiction medicine, let me explain. There is a small cluster of nerve cells in the brain called the locus ceruleus. Locus referring to a small focus of neurons, and ceruleus refers to the fact that it has a bluish color under the microscope. Okay? That particular area of the brain is what releases our stress hormones, like adrenaline. It turns out that opioids, including kratom, suppress that area in the brain. So when you're under the effects of opioids, things are calmer. When you're in withdrawal, that little nucleus in the brain goes into overdrive and floods your body with stress hormones, which is what makes opiate withdrawal so bad. When a medicine activates the alpha-2 receptor in the brain, it suppresses the locus ceruleus again, and clonidine suppresses that nucleus clonidine is a medicine that activates that alpha-2 receptor and suppresses that nucleus from releasing the stress hormones. And I want to make sure I get the name of the medicine right. It is lofexidine. That's right. Lofexidine is basically a cousin of clonidine that's on patent, meaning that it's a pharmaceutical company that's taken a cousin of a medicine that already works and rebranded it to make money. So there's tizanidine, which is a muscle relaxant known as Xanaflex, that is also an alpha-2 agonist like clonidine and lofexidine. And my perspective is, why would I use a brand name drug when I have generics that are just as good? If somebody said, I want lofexidine, I would say, let's see if your insurance covers it and how expensive it's going to be. Alternatively, we have clonidine and tizanidine, which can do the same. I have not used it because it's expensive.
Yeah. I guess a more general way, let's say somebody wants a prescription to help with the withdrawals. They're dead set against Suboxone or any of those types of meds. What would you recommend as a prescription to help with withdrawals from kratom?
Sure. So the first option is they can go to methadone. So methadone is a full opioid agonist. It is dosed once a day in a methadone clinic. The average doctor cannot prescribe, myself included, methadone for opioid addiction. They have to go to a methadone clinic. And then the medical director of the methadone clinic supervises their methadone dosing. Now, that involves going to a methadone clinic every day. And with success, you can eventually get about 2 weeks of medicine to take home and manage it on your own, but you're still tied to the clinic. Let's say somebody says, doctor, I would like to withdraw off of opioids. Can you make my withdrawal less bad? And the answer is yes. As I mentioned, we have the alpha-2 agonists like lofexidine, clonidine, and tizanidine. They blunt the stress response in the body and make the withdrawal less bad. And then we just add in a bunch of non-addictive meds that target specific symptoms. Do you have nausea? We will give you an antiemetic or a nausea medicine. Can you not sleep? We will give you a non-addictive sleep aid. Are your legs restless? Let's try some gabapentin. Are you having abdominal cramping? Let's give you an antispasmodic. So I usually give people like 8 to 9 different medicines that target individual withdrawal symptoms to make them feel more comfortable.
One last question about prescriptions and all this. The biggest complaint about doctors and the prescriptions of Suboxone, there's this belief that there's some big financial incentive that you're making money off of it. If I understand right, even Suboxone is now generic. So even the drug manufacturer is making less money. But do you have any financial incentives? And is the manufacturer like making hands over fists on the backs of people's addictions?
So the answer is it depends. And this is really important. And you can actually find this. It's publicly searchable. Let me see if I can find this here. It is, I think it's Docs. It used to be called Docs for Dollars. And then they just redid it. Okay, the Docs for Dollars database. I will find this in just a second. Okay, so it was an old website by ProPublica, which is a public watchdog. That was called Dollars for Docs. Now it's called Open Payments Data. So if you Google the term Open Payments Data, the website is openpaymentsdata.cms. I'm going to look myself up right now, Casey Grover, and I have gotten, let's see, okay, so you can find me, and I have gotten $20. So I really try to distance myself from drug companies because this is publicly searchable data, and I do not want to have a conflict of interest. Now, that being said, there is a cardiologist at my hospital that has made over $300,000 from device and drug manufacturers. Okay? It depends. If you're working with a doctor and you're suspicious, look them up. Okay? openpaymentsdata.cms.gov. And you can see, are they getting paid to be a speaker for the company? Are they getting free meals? This is a thing in medicine. For me, as a doctor that does not take money from any pharmaceutical company, I get paid exactly the same if I prescribe brand name or generic. The only kickback would be is if I offered to be like an expert for the company and be like an expert reviewer of their products, or they wanted to educate me and they take me out to dinner, or I am on their advisory board or I lecture on their behalf. There is absolutely some not so nice relationships between doctors and drug and device companies. And thank goodness it's publicly findable. So yes, the last drug dinner I attended was for the competitor to Sublocade. It's the other shot for buprenorphine called Brixadi. And I actually declined dinner. And the pharmaceutical rep was awesome. He's great. He knows I don't want to be paid by anybody. I just want to come and listen, make my own opinion, give somebody else my dinner. And actually, you have to, as a doctor, when you go to an event where they give you food, you actually have to sign in because this is publicly tracked. You have to sign in the I'm not eating sign-in sheet and the I am eating sign-in sheet. So we're trying to get some accountability around this. But yeah, when I was a medical student, it was like every week there was a drug-sponsored meal and you'd go home with pens and T-shirts. Yeah, so I think your patients, I think your colleagues and my patients have the right to be suspicious, but just look up your doctor. If you have questions, just look them up.
Why do you prefer Suboxone over Brixadi?
Oh, the Sublocade over Brixadi?
Yeah.
It has a longer tail. So we're still learning. So Sublocade's been around for a few years and Brixadi's been out, I think, for about a year, maybe 2.
Okay.
And the idea is that if you get a shot of Sublocade, that's the once a month injection of buprenorphine from the company Indivior, you test positive for buprenorphine in your urine for about 3 to 4 months, even though the shot's supposed to be given once monthly. And that's that long tail where it stays in your body that allows me to get people off of buprenorphine fairly easily. Now, Brixadi is the shot made by Braeburn. Yeah, that's the other manufacturer. It's a lot smaller and the needle's smaller. So the lump under your skin from the Sublocade is about the size of a garbanzo bean. For Brixadi, it's like smaller than a BB. So if you don't like shots, or one of my patients, he's so funny. He has a 6-pack, and when he would flex his 6-pack, you could see the Sublocade, and it messed with his 6-pack. And he's like, Doc, this is not working for me. So I put him on Brixadi. So Brixadi, we don't have as much data on how long it lasts, but anecdotally it has a shorter tail. So if somebody says, I want to stay on the injection, I usually offer them the Brixadi. If I'm worried about their follow-up, like they're not 100% ready for treatment, I'll go with the Sublocade, because if they miss 2 weeks of their appointment, they've still got enough in their system to stay protected. So Sublocade is my preferred product. But again, I have no financial relationship with either company. I know both drug reps. They're very nice. I keep them at arm's length. Literally, if they want to bring treats for the office, I say, great, please do it on a date. I am not personally in the office.
Yes. Do you have any non-prescription options for treating addiction?
Yes. So when we talk about addiction, there's 3 basic treatments. We have medicines, we have group therapy or group meetings like Alcoholics Anonymous, Narcotics Anonymous, and we have individualized therapy. So the way I look at it is medicine helps people feel better faster. But the work of really getting sober from addiction involves understanding your previous life experiences, traumatic or not, that led you to use, understanding your triggers, understanding how to build resiliency around emotional stresses, how to come up with a toolkit to avoid relapse. So yes, my rule is 2 out of the 3. Everybody has to do 2 out of the 3. You have to see a therapist and get medicine, or you have to go to meetings and go to a therapist, or you have to go to meetings and get medicine, or whatever combination was left of the 3. It's like a 3-legged stool, right? You're most stable when you have all 3. You can kind of balance on 2, and you're really wobbly on 1. Now, that being said, there is also some literature out there that you can do acupressure and nerve field modulation of the ear. I'm actually going to have a podcast episode in the near future. Again, no financial connection, but there's a company that actually has a device that you can attach to the ear that does neuromodulation of the nerves around the ear, and it's been shown to reduce symptoms of opioid withdrawal. There's also been some research on acupuncture around the ear that has the same thing. I have put one device on a patient. He noticed a huge difference. So I'll be coming back to that later this year on my podcast. I have one patient that uses hypnotism to help her quit alcohol, and she's having some success. This goes back to the mayonnaise on the left ear phenomenon, is that if you told me, Charlie, Dr. Grover, mayonnaise on the left ear keeps me sober, I would buy you a jar of mayonnaise, right? So it could be exercise, Spartan races, CrossFit, dirt biking, therapy, whatever it is. But you have to dig into the fact that substances allow us to cope with unpleasant feelings, and we have to find a way to address those without the substance.
Great. We're finally switching gears. Enough Suboxone talk. One issue that many kratom quitters have is pause.
Oh, gosh, yes.
Yes, and that was one of your publications in the Journal of Addiction Medicine in 2023. Could you give an overview of pause?
We don't understand it. I'm going to stop there for comedic effect. Hopefully someone found that funny. Okay, let's actually go into it. Okay, so it stands for post-acute withdrawal syndrome. There's loads of synonyms. Protracted withdrawal, subacute withdrawal. Here's how I think about it. Okay, so drugs and alcohol have a profound effect on the brain chemistry. Sometimes it's fairly clean. Alcohol affects the neurotransmitter GABA and the neurotransmitter glutamate. We know exactly how alcohol works. Kratom is messy. Kratom affects multiple receptors. It affects the enzyme cyclooxygenase. It has a stimulant-like effect. It has an opioid-like effect. It actually affects the alpha-2 receptor. Kratom is messy. Now, the other thing is that the prolonged exposure to substances secondarily affects other systems in the brain. So there's what's called a substance-induced mood disorder, which is where you can get depression because of your addiction. Or you can get a substance-induced psychotic disorder, where you're hallucinating because of the substance. In other words, the substance has a very specific lane it affects in the brain, but it's almost like you're driving through snow. The snow gets pushed to the sides. That lane changes other systems in the brain secondarily. And so withdrawal is coming off of the substance. Post-acute withdrawal is the other systems in the brain trying to correct themselves. And this goes back to, again, it takes up to 2 years for the brain to fully heal. And part of that is learning emotional resilience, learning coping strategies, understanding mindfulness about when you're feeling what you're feeling, and then letting those other secondary systems heal. For example, the serotonin system regulates our mood. That's an oversimplification, but think about selective serotonin reuptake inhibitors like Prozac or Lexapro. A lot of times, what we do in post-acute withdrawal syndrome is we use psychiatric medication to make those other systems work better. So I'll pick on you again, Charlie. You're coming off of kratom, we weaned you off of Suboxone, and you're horribly depressed and can't sleep. That's the rest of your brain systems trying to figure themselves out. We might put you on a sedating antidepressant to help you sleep at night and help that system get better faster. Now, there are a couple of things that we know make pause get better faster. Number one is exercise. Okay? Exercise is very important to heal various systems in the brain, including the serotonin system and the reward system, which is the dopamine system. Okay? Other things, good sleep. And that's very hard for many people in early recovery. A non-addictive sleep aid can be helpful. It could be something like melatonin. It could be something like trazodone. I would definitely stay away from the benzos because those are addictive and will start to have ripple effects in those other systems. Okay? Positive human interaction. That's where mutual support groups like Alcoholics Anonymous come from. If there are positive communities online around getting sober from kratom, someone giving you a virtual high five on your 30-day sober day, that's positive human interaction that helps healing from post-acute withdrawal syndrome. And then it's just sometimes medicines targeting symptoms. If you're super anxious, we might give you a non-addictive anxiety med while you work with a therapist to address your anxiety. It's essentially targeting symptoms with non-addictive medication, exercise, therapy, and working on positive human connection and good sleep.
Excellent. I love that analogy of the plow too. That really works.
Totally.
Early in your career, you co-wrote a paper or a couple of papers on drug-seeking behavior. And then a couple of years later, you did a commentary entitled News, It's Time to Retire the Term Drug-Seeking. Can you explain what the term refers to and what your early research showed on it and how you came to recommend retiring it?
Yes, great question. And you've clearly done your homework. So yes, when I was a resident at Stanford, it was in the early 2010s. And we would see people coming in essentially begging for prescription opioids. And we called that drug seeking. Their focus was not on a specific treatment or a diagnosis. It was specifically the request for a single medication or class of medication like opioids. And what we thought at the time was that they were just all addicted and needed to be told to get lost. I actually was told one time to push naloxone to make a patient suffer. It hurts my soul to say that, given what I know now, but that goes back to the stigma around addiction. Drug seeking was the idea that patients come in and say, I need Norco. That's hydrocodone. That's the brand name is Norco. Or they come in and say, I need Valium. That's diazepam. That's a benzodiazepine. They are seeking a specific medicine. Now, what is that really? In my humble opinion, now, drug seeking allows the doctor to prematurely close the case, judge the patient, and discharge. In other words, oh, it's just drug seeking, off you go. Now, really, I think now of drug seeking like nausea. If you go to the doctor and said, I'm nauseated, yes, they may give you a medicine for nausea, but why am I nauseated? Is it my gallbladder? Is it a medication side effect? Is it acid reflux? Do I have an ulcer in my stomach? In other words, I could very easily, if you came to the ER with nausea, say, oh, it's just nausea, off you go. But I didn't actually get into the why. So with drug seeking, is it active addiction? Is that person craving their substance and they're trying to get it? Is it withdrawal and dependence? Are they feeling horrible because they're in withdrawal and they just want to feel better? Is it untreated pain that makes them want to get an opioid? In other words, I started researching drug seeking as I began my journey of understanding addiction. And at the time, that was considered a definitive diagnosis. But as I have learned, drug seeking means the doctor needs to stop and ask why and figure out what that unmet need is. Now, there's more to this. Before I started asking the question, why do you use the substance that you do? What does it do for you? I could stop and say, oh, you've got an opiate addiction. But the question is, why do you have an opiate addiction? Are you genetically predisposed to have that intense euphoric response with opioids? Were you sexually assaulted when you were 10 years old and you've never coped with it? It's almost like drug seeking was not even the tip of the iceberg. It was like a single snowflake on the very tip of the iceberg. It was so shallow as to the understanding of what was really happening. And as I've learned more, and I have much more to learn, I'm starting to understand that there's like levels and levels and levels of why. And only if you get to the real why can you actually help the patient.
That practice, the drug seeking and just all the ripple effects, it's still in effect. Like we have a lot of listeners that say they don't even want to talk to their doctor about their kratom addiction. And it's another barrier to getting prescribed Suboxone because they don't want it to be on their chart or reported to the drug monitoring database that they're on it. So
you are 100% right. So I lecture professionally on stigma. In fact, I just released an episode of my podcast about stigma. And yes, it is a real thing. And of every medical condition which can have stigma, and there are hundreds, almost any medical condition can be stigmatized. By far, addiction is the most judged of anything in medicine. And it breaks my heart. But that is what it is. I'm certainly trying in my little corner of California to educate people about stigma and how it's horribly detrimental to patients. But there's so much more work to do.
Yeah, that leads into another commentary you did where you're advocating that we don't, as a society, as a professional doctors, and even as patients, there's less stigma around like taking a medication for asthma. But there's all this other extra baggage if there's an addiction instead.
Let me just explore that. So let's imagine a person has type 2 diabetes and their blood sugar goes up to 250 after they forgot a dose of medication or ate something very sweet. We don't call it a relapse on diabetes, but functionally, that's what that is. Or for me, with my asthma, I do have asthma. If I have to use my asthma inhaler, that's not a relapse on my asthma. But yet, with addiction, that's what we call it.
Yes. Yeah. And to even dig deeper, asthma is probably a condition that has a less baggage, but people can be judgmental about diabetes and, and obesity.
Yes.
But I don't think it's stigmatized as like an addiction, especially to the street drugs, which just has all sorts of stereotypes and sensationalism around it. Thank you for this. It's been a great interview. We went a little bit longer than most of our interviews, so I thank you for your time. We do like to try to light things up a little bit, and one of my co-hosts is better at asking these questions at the beginning, but what kind of music do you listen to?
I'm going to give you the honest answer, and then I'm going to make fun of myself.
Yes.
So the answer is absolutely anything. My playlist will have Dr. Dre and Tim McGraw and Kiss and Motley Crue and Taylor Swift all in the same playlist. But my wife and daughter make fun of me that I have the musical taste of a 16-year-old girl. I listen to a lot of pop. That being said, my all-time favorite band is probably Motley Crue. They write very openly about their addiction, particularly Nikki Sixx, somebody that I would love to meet just because I've read a lot of the work that he's done around addiction. So yes, I'm going to say the song I'm digging right now is Lick It Up by Kiss. I worked out to that this morning.
All right. Do you have any pets?
Yes, I have a husky mix. We think she's an East Siberian Leka. She's an all-white husky-looking thing that we adopted from the SPCA. And I have learned a ton about her. I have learned a ton about addiction from her. And let me briefly go down the rabbit hole here. When we went to the shelter, she was so scared. Tail between the legs, fearful body posture. We almost didn't adopt her. And then one of the staff from the animal shelter walked out and she lit up like a little Christmas tree. That dog smile, wagging, happy, and we realized she was just scared. So we took her home. And within about a week and a half, she was a new animal. And I have a saying with my dog that now that she is safe and loved, she is a happy animal. And that's what all of us just want to be, is safe and loved. And my patients who have been traumatized struggle to find that. And that's what often leads them to substances. So my dog's name is Pixie. She's downstairs right now. She and I walk 3.5 miles every morning. And yes, I have learned a lot about her. And I strongly believe in the power of emotional support animals in the treatment of addiction if it's a good fit for the person.
Nice. Yes. You talked about your podcast. Could you just tell us a little bit what you're trying to accomplish with it?
So I'm a doctor, not a podcaster. So let me start with that. So in 2021, I said, shoot, I'm about to be an addiction medicine doctor. I probably should learn this pretty well. So my initial podcast came out as a very long and unwieldy title. Gotta love being a doctor because we don't know any marketing skills.
Yeah.
It was called Addiction in Emergency Medicine and Acute Care. And I have seen so much addiction in my 14 years in the ER. I thought ER doctors all over the nation and the world would love a podcast focused on addiction in the ER. And my listenership really plateaued. And that was when I was practicing mostly emergency medicine. And I left the emergency department last year. And so I renamed the podcast Addiction Medicine Made Easy. What I can tell you as a doctor is really practical, good information about addiction is hard to find. And that's what I try to do. Sometimes it's a very geeky clinical question. Can we use the drug topiramate, also known as Topamax, to treat alcohol addiction? Other times it's on much broader topics. Like my podcast coming out on Monday is an interview with a woman who identified as having an alcohol addiction and was sexually assaulted. And we talked about the relationship between sexual assault and her recovery. Fascinating interview. I've also got one coming out probably in about 2 weeks about different types of psychology as it relates to addiction. And then I've got some other ones coming up on what an ideal rehab would look like and what harm reduction really means. I started very scientific and I've moved much more towards listening to people's stories and what we can learn about it. Because addiction, the best thing I do as an addiction doctor is to get to know people and be nice to them. And then I can start to make progress.
Yeah, I've learned a lot. I've started becoming a loyal listener every Monday. I can wake up and I know.
Thank you.
Yeah. And I'm going to put you on the spot. Like one of your recent ones, I think was a talk that you gave to a high school students or something. I know many of us like laugh at the DARE program, but I do think that we need to, and I know you're a parent too, we need to educate our kids about the dangers of drugs. And how can we talk to young people without being ridiculous about, yeah.
So I lectured to over 5,000 students last year, and I have a specific talk I give to parents on how to talk to your kids about drug and alcohol use. The world is full of vices. Kratom, pornography, sugar, processed food, meth, you name it. There are vices. We must teach our kids how to live in a world full of vices, just as we teach them how to ride a bike and cross the streets safely. In my humble opinion, you as a parent, not you, Charlie, but the global you as a parent, need to be talking about drugs and alcohol regularly at the latest as they transition into 6th grade. I almost always ask my patients on my first visit, how old were you when you started using drugs and alcohol? The most common answer I get is between about 11 and 14. That's middle school. So we need our kids to be ready to have some baseline knowledge as they enter middle school. Now, we all get defensive as human beings. So if I get in your face and ask you, what'd you do after school yesterday? It puts you on the defense. And I often tell parents, frame it as an external problem that your family wants to be a part of the solution of. I think my grammar was wrong. Let me say that again. Frame it as a problem that is someone else's that you want to help with. Hey, I heard about fentanyl on the news. What can our family do to help? What do we know about it? Do we know anyone who uses it? Should we carry naloxone? I think that's the easiest way to do it. And be persistent as a parent. If your kid blows you off and puts their headphones on, don't give up. Find another time. Are you in the car? Are you doing laundry? Is it meal prep? Is it dinner time? So yes, absolutely. But we also need to talk to our kids about pornography and vaping and the internet and social media. We teach our kids to drive, but we don't teach them how to drink alcohol when they go off to college, right? So actually I have a course at one of the schools I work with on tips for success for high school seniors in the spring of their senior year. You're going to get bombarded with drugs and alcohol next year. Let's go through this. Beer is 5%. Whiskey is 40%. Wine is 12 to 15%. How much alcohol fits in a solo cup? Why are solo cups at parties? What is a keg? I just need to have them have some baseline knowledge. That's very different from DARE. DARE was, you won't do drugs, right? Drugs are bad, right? And what we found with DARE is it changed kids' minds about drugs, but not their behaviors. And so my approach is, you are going to be offered drugs at some point in your life, if not next week. Are you ready to say no? And if you want to say no, practice today. You are going to be given a drink at some point in your life. Do you know what beer is? Do you want to drink whiskey or beer? Why? How much beer is it? Is it 8% beer? Is it 5% beer? Is it 2% beer? Is it kombucha? I just try to give them some baseline knowledge. And for some of the kids, particularly the younger ones, I tell them, if you don't want to use drugs and alcohol, plan your escape now. Two sweet little girls came up to me after one of my lectures and they were like, Dr. Grover, thank you. We made a code word that if we're at a party, we'll tell each other so we can get ourselves out of the party and not drink or use drugs. I was like, yes, my daughter knows that, hey, if you are at a party, you can call me 24/7 and I will come get you.
I had one time had a pro kratom person state that we can't warn about kratom because it will make it more enticing to the kids. So we,
yeah, what I would probably say is we have to point out that it is habit forming and has a withdrawal syndrome.
yeah,
Right. So what I have heard is that some people can have a little kratom in the morning, like their coffee. It can make them more productive and they go about their day. Right. Now, that's not everyone. And I'm obviously on the Kratom Sobriety podcast. So I don't want to make kratom sound good, but there are people that can use it in small amounts and control it, just the way some people can be on opioids for pain and not have an issue. Some people can have 2 glasses of wine a week, right? Let's call kratom what it is, which is a substance like alcohol, tobacco, or whatever else that some people can dabble with, some people get addicted to. My biggest issue is that people don't realize that it causes dependence and withdrawal, and then they're stuck. Because sure, if you wanted to use it like when you're tired and wake up, sure. It's the withdrawal and opioid dependence that I think is what makes Suboxone the lightning rod, because once people are dependent, they're stuck. And Suboxone doesn't get them unstuck. It just gets them off of kratom.
Yeah.
It's the dependence that I get frustrated with, that people don't know that this substance that they think makes them feel better is now their worst enemy because they can't quit it without feeling horrible.
I know opioid hysteria is not helpful, but I do think it would be more beneficial to actually the industry and to society to call kratom a natural, atypical opioid.
Sure.
But this debate about the marketing, it's a little bit like trying to say Pennsylvania is not a state because it's a commonwealth. It's a state. That's what Pennsylvania is. And for the most part, kratom is it's like an opioid. But it's just the marketing and the advocacy push to pretend, make it like it isn't. I think that's the crux of the problem, is that.
So here's my professional opinion. I treat kratom like an opioid.
Yes. End of the sentence.
That was the end of my sentence. I treat kratom as an addiction doctor like an opioid.
And we could end the podcast on that note, but I want to give you an opportunity. Was there anything we didn't talk about or a question that you'd like to ask before we say goodbye?
No, I just offered to you. I love to podcast. I have an expertise in addiction medicine. If I can help with content review, or if you need me back in a future episode, I would consider myself fairly knowledgeable on kratom as a doctor. And as we've talked about, most physicians are fairly clueless. So yeah, I'd be happy to come back. And if there's other questions that folks have, or we want to come back in 6 months and do a follow-up, or if there are listener questions, send them my way. I'd like to get your listeners the best information I can provide around addiction, and specifically around kratom, whether it's kratom use disorder, kratom dependence, kratom withdrawal, whatever it may be.
Thank you so much for your time today. And this is going to be a great episode. I really appreciate it.
I am honored to be on your podcast, and we'll be in touch.
Take care.